Dr. Hochhaus, thank you for joining us on MD
Pleasure.
Newsline. It's a pleasure having you. You did some great presentations here at EHA. Please, for those that don't know, please introduce yourself to our audience.
Yeah, my name is Andreas Hochhaus. I'm professor for internal medicine, hematology, and oncology at the Comprehensive Cancer Center, Central Germany in Jena. And I have been involved in CML trials now for 30 years. I think that means I started with interferon, with imatinib, with the second generation drugs, and now with the new drugs which we present here.
Yes, and this is a long time, so I'm sure you've seen this field change quite a bit. Tell me a little bit about what you presented, but really, first of all, I would like to know um, how the field has evolved over time and how our understanding of the need for some of the treatments that you discussed at the conference, how has that evolved over time?
I think that's a very, very important question because some people claim that CML has been resolved. That means all the questions have been resolved, which is not the case. When we ask our patients, how do you feel on your treatment? Most patients say we have side effects, our quality of life is impaired, and we have daily problems. And of course, that's an important aspect for compliance, the tolerability of the drugs. Therefore, I think to improve tolerability is an important issue. But we see also resistances to the treatment. We have early after the introduction of imatinib 25 years ago, we have seen mutations, BCR-ABL mutations, which caused resistance, but we had nothing else available at that time. Then came the second generation inhibitors, nilotinib, dasatinib, bosutinib, which rescued some patients with these mutations, and also the third generation inhibitor, ponatinib, of course. But they are multi-kinase inhibitors, and multi-kinase inhibition means there is off-target inhibition, and this off-target inhibition may cause side effects, very specific side effects. For nilotinib and ponatinib, it's a cardiovascular side effect. For nilotinib, also hepatotoxicity. For dasatinib, the pleural effusions. And also imatinib has side effects on the long term, the renal insufficiency and some gastrointestinal problems, the muscle cramps, and also the edema with imatinib are a problem. These problems have not been recognized 25 years ago when we had only one drug available. But now, having more choices available, it's very important, and our key factor in the choice of the treatment to improve the tolerability of these drugs. And that's, I think, the main issue. And we can improve the tolerability on a daily basis, but also on the long term when we enlarge the cohort of patients which is eligible for treatment-free remission. These are, I think, the main aspects for improvement of CML management.
And so you gave two separate talks at the conference. Can you give me just a brief overview? Because I know some of the questions that I have for you are maybe can overlap to both, but I just want to give the audience an understanding of some of the main topics.
We have two very new trials which are in phase 1 studies, the Enliven-001 and the Turns 701 drugs. 701 will be presented or was presented by Tim Hughes. I will focus on Enliven-001. That's an ATP competing drug. That means in the traditional mode of action, but the pharmacodynamic and pharmacokinetic profile is much different from previous drugs. That means it's not cytochrome dependent. That means it has a different metabolism. Therefore, it's an ideal drug for combination, for instance. And also hepatotoxicity will be reduced with this drug. And it's not dependent on PGP, for instance. It's not dependent on the import-export enzymes in the cells. And it's a once-daily drug which can be used after a meal. These are major improvements of the management of CML. But most importantly is the molecular profile of the drug. It does not inhibit many of the kinases which are inhibited by other multi-kinase inhibitors. For instance, KIT, SRC, PDGF receptors, FLT3, are not inhibited by Enliven-01. Therefore, it's more specific against BCR-ABL. And second, it inhibits mutations very precisely, for instance, threonine 315 isoleucine, which are not inhibited by others. That means the combination or the alternative treatment with Enliven-01 after or with the other drugs is feasible, and therefore the development of these new drugs is worth. And we support this very much in the phase 1 trial. Phase 1 had a typical design, 3+3, a step-up design starting with 10 milligrams. Now we are at 120 milligrams. There is no DLT. That means drug is well tolerated. And the profile against heavily pretreated patients with efficacy is rather good. But of course, the main parameter in the phase 1 trial is tolerability, which is excellent with this drug. I like this drug. I treated personally 12 patients in this trial, and I have a very good feeling. But the data which we presented here at EHA are positive as well. We are now currently in the 1B phase. That means we support the previous findings. The 80 milligram cohort once daily is full, and we now randomize the patients without mutations between 60 milligrams and 120 milligrams. That's ongoing. And in parallel, we have a cohort for atypical BCR-ABL transcripts, which will be analyzed separately, and a cohort for the patients with the more problematic threonine 315 isoleucine mutation. Means we report here the efficacy of the step-up approach, the phase 1A cohort, and the tolerability at these doses. It's obvious that the duration of treatment is much longer than the duration of the previous treatment in these heavily pretreated patients. Therefore, I think the tolerability has been proven already, and we need, of course, go more forward in second line and into first line later to demonstrate the efficacy in the earlier lines.
Thank you. So I want to step back a little bit and kind of talk about something that you mentioned in one of your presentations. Like I said, you mentioned this 2002 NEJM study showing pre-existing mutations in chronic phase CML. How did the discovery change how we approach TKI therapy today?
That's 25 years ago. That's a long term, but it's important because it's an example for resistance mechanism in cancer in general. That means the more specific you are against a cancer cell, the more methods, genetic methods, find the cell to escape this selective pressure. And we found this very early in the imatinib development, that a patient who does not respond optimally to imatinib, that means have a higher tumor load over time, will have mutations eventually. And this was found in CML, but also in GIST, for instance, which has been treated inhibiting the KIT gene with imatinib in the same way, but in a solid tumor in this case. That means it's a general phenomenon that the molecular targets may escape with point mutations, who then grow up either in the tumor, like in GIST, but also in the bone marrow and the peripheral blood, like in leukemias. And of course, it was important to detect the reason for resistance and to find a way to overcome it. The first way, which we did 25 years ago, was to stop the targeted therapy and to go back to chemotherapy, which is not needed anymore because we have more targeted options available now. We could use the second generation drugs, we could use ponatinib, and we can now use new drugs like the myristoyl site inhibitors, most importantly, of course, asciminib, which inhibits the cancer cells on a different position and are therefore a very good option in late line therapies for resistant patients. Asciminib is a BCR-ABL specific inhibitor. That means it does not inhibit other kinases, therefore much better tolerated than any multi-kinase inhibitor. And it can be used as a monotherapy. This has been demonstrated in late-line therapies, led to the registration of asciminib in most countries worldwide for third line. But now we have the studies available in first line, ask for first and ask for start studies. And we know and we have proven that we can use this monotherapy in first line, which is very efficacious, more effective than imatinib and more effective than second generation inhibitors, has been demonstrated in 2 studies, ask for start and ask for first, and it's better tolerated. And this is proven now.
Talk to us a little bit about how this new line of treatment compares to previous benchmarks that we've seen in the past when you compare your results.
I want to focus now on the Ask for Start study, because this was presented first at ASCO 2 weeks ago and then here at EHA. And it had a new endpoint. We developed a new endpoint, which is a very robust endpoint to demonstrate tolerability, the time to treatment discontinuation due to adverse events. That means we have defined a very clear and very strict procedure how to manage adverse events in the asciminib cohort, but also in the comparator arm with nilotinib, to have the same level of actions according to side effects. And if the side effects were not tolerable anymore, then the drug was discontinued. And we expected in this study 65 discontinuations, and introduced in the protocol an interim analysis which was done at 50 events, and we demonstrated that asciminib is clearly advantageous when we consider this time to treatment discontinuation due to adverse events, with 16 events only compared to 34 events in the nilotinib arm. Therefore, with this very robust new endpoint, we have demonstrated the longer and better tolerability of asciminib. But we looked also at efficacy, but of course it's an interim analysis, therefore we have only 12-week data available. But after 12 weeks, we expect in the recommendations, in the guidelines, 10% BCR-ABL. But what we have seen here is a clear advantage also for the so-called MMR. That's a 3-log reduction of the tumor load compared to the baseline, to the standardized baseline. That means 0.1% BCR-ABL. 2 logs more than the 10% was already achieved with asciminib in significantly more patients than with nilotinib. That means for tolerability, we have proven the advantage, but also for efficacy.
So when it comes to some of these new line treatments, when we look, I mean, right now we're in Milan, but when we look at treating patients in America, you know, hospitals have different levels of access to medication, access to, you know, molecular testing and things like that. How do you see the need for access to these types of treatments evolving across various countries? What are some of the, maybe have you thought about how this might be implemented in places with different levels of resource?
No, even in places with very good resources, optimal resources, we see differences. We are very jealous in Europe that you have the registration in the US. We don't have the first-line registration for the time being. We expect this for the end of 2025. But at the moment, we don't have it, and we cannot use asciminib in first line outside of clinical trials for the time being, but we expect this very soon. But the optimal treatment of CML, as you said, includes not only access to all the drug options, but includes also optimal molecular monitoring. And that has been developed in Europe in a marvelous way, in a very good way. We have standardized approaches. We do the molecular testing the PCR in a standardized fashion. That means we can compare the data in Italy with the data in Germany, and even the data between different labs can be compared easily. That's not the case worldwide, and as far as I know, not the case in the US as well. And that's a disadvantage for the patient management, because we set our endpoints. We have our milestones which should be achieved during the treatment in an optimal fashion to achieve treatment-free remission, to know that the patient is on the way to treatment-free remission, and on the other side also to select the patients who are resistant to treatment, need molecular testing for mutations, sequencing, and then an alternative treatment. And most importantly is, of course, the management in treatment-free remission. To do a safe treatment-free remission, we need very clear guidelines when to stop the therapy in a safe way, and then how to follow up to detect an relapse very early, not when it comes to an hematological relapse. That's too late. We need to detect it when the PCR is increasing over time. And with this approach, we have a safe management with overarching, of course, improving the quality of life.
And when it comes to quality of life, how do you assess and address quality of life in patients receiving Enliven? And have you observed improvements compared to prior therapies? What were some of those kind of benchmarks?
Yeah, in a phase 1 study, of course, we have strict rules according to the study design and the registration, large questionnaires, and so on. But I want to more focus on the daily routine. In the daily routine, I think we should consider quality of life in the discussion with the patients. Some colleagues use questionnaires, which can be, of course, simplified compared to the questionnaires in clinical trials. Some patients like this to fill in a questionnaire before they talk to the doctor, but in the discussion with the patient, it's so important to focus on quality of life as well, to consider the daily problems of the patients and not only the lab values and the clinical symptoms.
Mhm. So let's just talk a little bit about, mutation coverage and mechanistic insights, just kind of going back to that. So in your presentation, was there evidence of any differential activity against specific mutations like T315I, or those emerging after a failure?
We know that a patient with a mutation has a different sensitivity profile to the drugs than a patient with unmutated BCR-ABL. And that's very specific according to the specific mutation, and very specific according to the drug which is being used. Therefore, we need tables. We need a guidance which drug could be used at which dose in which mutations. That's obvious in the phase 1 trial with Enliven-01. Here we know from preclinical analysis which mutations are sensitive and require the standard dose. Of course, in the phase 1, we have all the doses available because we did a stepwise approach, but not systematically according to the mutation. Therefore, what I already mentioned, this cohort with the 315 mutation, which is, I think, the most important and most frequent mutation, was implemented to have a clear guidance eventually which dose should be used with this mutation. Maybe a little bit higher than the standard dose which comes out, but that's still open in the phase 1. For asciminib, we know these results. We know that asciminib inhibits the 315 mutation, but requires a higher dose. We need a 5-fold higher dose than in the standard situation. Standard situation is 80 milligrams per day. For 315, we need 400 milligrams per day. But it's manageable, and therefore important that we design an early clinical trial like a phase 1 trial in a way to be very versatile eventually when it comes to resistant mutations, and to know which dose should be used in which situation.
Are there any other thoughts you have on how you might foresee individualized titration becoming standard practice?
Yeah, we have now 6 registered drugs available, We have other drugs in the pipeline. That means we have a huge armamentarium of medical treatment in CML. Therefore, I think the discussion with the patient, what are your treatment goals? Is your treatment goal just to survive without side effects? Or is your treatment goal treatment-free remission? Is your treatment goal to achieve an optimal quality of life? Is so important. And we should start this discussion after diagnosis immediately when we select the first-line therapy and inform the patient what are the options, of course. When we only introduce one drug and provide this drug, that's not shared decision-making. We should introduce the shared decision-making in this process, starting at diagnosis, but going step by step to involve the patient into the treatment options and into the decision making in the therapy. This will improve the compliance of the patients, and this will improve quality of life, and finally, of course, efficacy.
Yes. Are there some ways that we haven't discussed that you see maybe Enliven's role evolving in the CML treatment algorithm, especially for patients with multi-TKI resistance or intolerance?
You ask for Enliven. Since this is phase 1 only,
Mm.
I think that's an important question, but too early.
Sure.
I would ask this question for asciminib. Yeah, it's because asciminib is registered in third line and in the US and Switzerland and other countries also in first line. I expect and I hope that my colleagues will agree on that asciminib should be used in a majority of patients in first line because it's efficacious, it's well tolerated, but it should, of course, demonstrate a long-term effect on the quality of life. Therefore, it's important to measure this and to show a major step. I see this major step in the revolution of CML therapy, since it's more expensive, of course. Any new drug is expensive, and we need to consider, of course, economics here. But if we see a major improvement and can stop the treatment eventually in treatment-free remission, then we reduce the overall costs again.
What are your thoughts on combinations or potential combinations with allosteric inhibitors in earlier lines of therapy? And what patient populations do you think this would benefit from this strategy?
Yeah. Asciminib was developed initially as a combination therapy because it inhibits a different site. It binds to a different binding site in BCR-ABL, the myristoyl binding pocket compared to the ATP binding pocket. Therefore, it was obvious to try a combination between ATP competing drugs and asciminib. This had been implemented into the phase 1 trial with different dosages, different drugs, but was compared to the monotherapy as well. And it was obvious that the tolerability of the combination is less good than the tolerability of the monotherapy. And the efficacy was not much better with the combination than with the monotherapy. Therefore, for the phase 3 registration trial in third line therapy, ASSEMBLE trial, asciminib 80 milligram per day monotherapy was chosen and was compared to bosutinib in this case. And then eventually in the first line trials, asciminib 80 milligram was compared in the Ask for First trial to all the standard of care drugs available, and in the Ask for Start trial compared to nilotinib. Overall, these trials demonstrated the advantage for efficacy, but also for tolerability. And therefore, I think the translation into clinical practice is that asciminib is the best available drug for first-line use.
Mm. When it comes to overall implications on clinical practice and guidelines, do you anticipate that new tolerability endpoints will be incorporated in the future clinical guidelines or regulatory assessment for CML therapies at all?
When we talk about tolerability, we talk, of course, about classical adverse events. Adverse events can be disease-related in the beginning, in the starting phase of the therapy. this should be separated from drug-induced adverse event, the real side effects of the drugs. And we talked a lot after the development of, during the development of imatinib about management of side effects. I think that's not in focus anymore because we can switch now, and we should switch the therapy when we see major side effects and when we want to avoid long-term side effects. For instance, with nilotinib, the aim of using nilotinib was to achieve treatment-free remission. If this is not achieved after 5 years of therapy, we should switch, because in the long term, we have a major risk of cardiovascular side effects. And this should be foreseen and implemented in our treatment scheme. That means we should know the potential side effects of all the drugs. In case of dasatinib, it's pleural effusions. And we should ask the patients for daily events, for daily side effects as well, which impair the quality of life. That means all these either long-term major side effects, also low-level daily side effects are important for the management and should be considered in our strategy. And that's, of course, feasible in all countries which have many drugs available and should be used in these countries. In countries where only a limited resources are available, of course, imatinib is still a very good drug, but we need to manage then the side effects as we did 25 years ago when imatinib was introduced as the only ATP competing TKI.
Mm. What are the main questions that remain in this field that you're looking forward to exploring?
We see in CML patients at diagnosis, but also in the course of the disease, additional mutations in other genes outside of BCR-ABL. That's an interesting phenomenon because that's molecular evolution. The cell is not dependent on BCR-ABL only. The growth of the cells may depend on alternative pathways as well. And the most important gene here is A6L1. And we and others, also the Australian colleagues, have done large cohorts, sequenced large cohorts of CML patients at diagnosis, and we have seen in about 8 to 10% of the patients A6L1 mutations at diagnosis. And actually, the likelihood to achieve a good molecular response is lower when these mutations are there. But also, and that's Australian data, the likelihood to get a BCR-ABL mutation on asciminib, the myristoyl site mutation, is higher. That means we have a problem here. We have a cohort of patients who may not optimally benefit from the monotherapy with asciminib. Therefore, we plan, and you ask for the future, of course, therefore we plan combination trials with asciminib combined with a multikinase inhibitor to overcome this disadvantage. I think that's an important step for the future. This may apply only to a minority of our patients. That means most patients can be treated with the monotherapy with asciminib, but we need to address this, and this will be the next step.
What do you think are the key takeaways for physicians that are working actively with patients based on these studies? What can they apply to their day-to-day decision making when it comes to treating patients?
First, inform your patient about the disease, inform your patients about all options available in the specific country. And then make a shared decision making with the patient. What are your treatment goals? What do you want to achieve? And consider the opinion of the patient. And then you will have a good compliance because the patient was involved in the decision making. And then use molecular monitoring as optimal as possible. It means 3 monthly in most cases, and consider the results of molecular monitoring for your decision making. That means if you don't achieve an optimal molecular response, you may look for the reasons for that. Maybe compliance, maybe side effects which are behind. That means we need the communication with the patient in this case, and consider the alternative options. If alternative drugs are available which overcome these compliance issues and tolerability issues, then you should use them. And if the patient wants to achieve treatment-free remission but is not in deep molecular response, You can switch therapy to have an alternative drug available, which may result in a better PCR response. We use the communication with the patient, we use BCR-ABL level, we use the side effect profile, and we use the mutation profiling to select the best available therapy at the specific time point.
Do you have any final thoughts that we haven't covered just on CML in general as you're, at the conference, things that have stood out to you as far as what your colleagues are working on that you're excited about?
My colleagues asked me, what about current recommendations for CML management? And we just finalized the ELN recommendations for the management of CML, and we cover, of course, treatment options, but also diagnostics, monitoring options here. And this paper has been accepted by Leukemia last week and will appear very soon in leukemia, and therefore we have a guidance how to manage CML patients worldwide based on these recommendations from an expert panel with 34 colleagues. I think that's a major impact on the management worldwide. But of course, on the local level, and you mentioned this already, each country has specific situations. And in Europe, we don't have the first line registration for asciminib for the time being. We are waiting for this, but we produced local guidelines, for instance, in Germany, as well, to cover the current situation, and these local guidelines will appear very soon. That means the field is evolving rapidly. Therefore, we need to update these recommendations again and again. I think after the first line registration, we should do working on the recommendations again to implement the first line use.
Thank you so much for your
Good,
time.
thank
We're
you.
looking forward to the next phase of the study.